Hello, I'm Matt Chen. I'm a fourth year med student at the University of Buffalo, and I have a case for you today. So this patient was a 52-year-old male, status post motor vehicle collision. He was the restrained driver of his vehicle that was stopped at a red light when two vehicles collided. One of these vehicles then ricocheted into the passenger front quarter panel, and he reports going to a local hospital with neck and low back complaints. X-rays were taken at that time, although we don't have the images available from that. He was discharged home with instructions to follow up with his primary doctor. Patient then initiated chiropractic care 3 times a week and was undergoing pain management and was prescribed tramadol and Flexeril. He denied any previous injury to the cervical and lumbar spine prior to the accident. So on presentation, he, on a scale of 0 to 10, where 0 was no pain and 10 being the most pain he's ever had, he reported a 7 out of 10 on average, and 10 out of 10 at its worst in the cervical spine. He reports radiation of pain to the right shoulder with associated numbness and paresthesias. He reports lower back pain, rates that at a 7 out of 10, and at worst a 7 out of 10. He reports the pain is centralized to the middle of his lower back and does not tend to radiate. However, he does report numbness and paresthesias paraspinally. He reports no bladder or bowel incontinence. His medical history is not significant for anything, and his review of systems was negative. Medications that he takes are ibuprofen, tramadol, and Flexeril. He has no known drug allergies. His social history is that he was not working and last worked on July 14, 2014. He denies alcohol intake, and he smokes 3 to 4 cigarettes a day. His family history is only significant for diabetes and negative for any major spinal disorders. So on physical exam, he's a 5'10" African-American male at 175 pounds with normal vital signs. He was A&O times 3, normal mood and affect. His musculoskeletal exam was that he had a normal gait, was able to stand on heels and toes, showing good balance and coordination, not using any assistive walking devices. Inspection showed no paravertebral muscle rigidity. Range of motion, so his cervical range of motion on flexion was 50 degrees out of 50 degrees. Extension was 55 degrees out of 60. Right lateral bending was 30 out of 45, and left lateral bending 30 out of 45. And rotation to the right 60 out of 80, and rotation to the left 60 again out of 80 degrees. His lumbar range of motion on flexion was 40 out of 60. On extension, it was 10 out of 25, right lateral bending 20 out of 25, and left lateral bending 20 out of 25. There's reported functional range of motion on the shoulders, elbows, wrists, hips, knees, and ankles. On strength, and he had 5 out of 5 at his left upper extremity, including intrinsic muscles of hands, grip strength, and they were firm bilaterally. However, he had 4 out of 5 strength that was noted at the right deltoid, the wrist extensors and flexors, and intrinsic muscles of the right hands. We had 5 out of 5 bilateral lower extremities, including on strength, including dorsiflexors, inverters, and everters of the feet. His straight leg raise was positive in supine and sitting position of the right and left at 60 degrees. And his deep tendon reflexes were 2+ bilateral, subpatellar and Achilles, and 2+ in bilateral upper extremities. His sensation was intact to light touch in bilateral upper and lower extremities and all major dermatomes. The only pathologic reflexes that were noticed was there was a positive Hoffman sign on the right only. So here in figure 1, we can see on his MRI, his axial and sagittal T2, MRI T2, we see some central disc herniation, the protrusion type. So you can see that over here. And you could see, and there's also noted to be moderate to severe degree of bilateral foraminal stenosis, which you can see over here. It's more pronounced here on the right side. The patient also had, at the C4-5 level, a broad-based disc herniation that was noted to be less than 2 millimeters. And then moving on to figure 3, here at the C5, C6, area, we see a slight retrolisthesis of C5 over C6. You can see this drop off here. With the disc herniation, with protrusion and posterior spurring, it was less than 2 millimeters. However, there's also moderate to severe bilateral foraminal stenosis, with worsening on the right. So the foraminal stenosis you can see over here, and on the next image is really where you can appreciate more of that stenosis. Here at the C6, C7 level, you can see a minimal broad-based central herniation, protrusion less than 2 millimeters, so you get a little bit of that protrusion here coming down. So then the question became, what was actually causing his radiculopathy? What were causing his radicular symptoms? So with the MRI, it shows the mild disc herniations that were centrally located, as well as the right foraminal stenosis. And the foraminal stenosis would have been there previous to the MVA. However, after the accident, the way the accident happened with the impact to the vehicle, the patient was hit on the passenger side. The impact would then cause a rapid right lateral bending of the cervical spine. And this trauma, with the IVF narrowing that was there of the moderate sphere variety, can cause the neural impingement as a result of the accident. And coupled with the small size of the disc herniations, it was more likely that the foraminal stenosis was the causative agent of the patient's radiculopathy. And this was also noted on the EMG, which further supported the diagnosis of the radicular symptoms. Moving on to his lumbar spine, he also had at the L3, L4 level, seen here in figure 6, a minimal diffuse bulge of the annulus fibrosus, and no significant foraminal stenosis. You can see a little bit of the bulge here. And at the L4, L5 level, while there is not a disc herniation, there is mild bilateral facet joint degenerative changes. So at the facet joints, there's some degenerative changes happening. And then moving on to the L5-S1 area, there is a slight retrolisthesis of the L5 over the S1 and broad-based disc herniation. Protrusion with posterior spurring and approximately 3 millimeters in the AP dimension. And there's also noted to be severe right-sided foraminal stenosis. So again, we're faced with the same question as before. If this patient's radicular symptoms in his legs were caused by, that was found in EMG, was caused by the disc herniation versus the foraminal stenosis. And again, based upon the small nature of the herniation, the central location, how the clinical picture is, it's more likely these symptoms would be produced by the foraminal stenosis that was pre-existing. And of note, the disc here was noted to be of a Modic type 2 change. So the Modic type changes, there are 3 classifications, and so the Modic type 1 change includes an inflammatory reaction with bone marrow edema and vascular congestion, and it will appear as a hypo-intense signal on a T1 weighted and hyper-intense signal on T2 weighted MRI, and as well as stir MRI. The enhancement is observed commonly after the injection of gadolinium. Sometimes Modic's type 1 inflammatory changes may be so pronounced they may mimic a spondylodiscitis. However, when increased disc signal and intensity on T2 weighted and or paravertebral or epidural abscess are seen, the more likely diagnosis there is infectious spondylitis rather than Modic type 1. So Modic type 2, which is what we are calling this one, is inflammation that entails the subchondral fatty conversion of the bone marrow, which can be seen over here as a hyper intense signal on both T1 weighted and T2 weighted imaging, and a hypo intense on stir imaging. Type 2 changes can be observed as frequently as 20% of cases in patients greater than 50 years of age, and usually located in the anterior 1/3 of the vertebral end plate, which is also seen in this case, anterior 1/3. And so Modic type 3 changes include sclerotic changes of the subchondral bone marrow. They appear as hypo-intense on T1, T2, and on stir imaging. So the patient was then deciding to continue his conservative treatment. He was being seen by a chiropractor 3 times a week. He was also continuing the pain management and also had a follow-up EMG. However, he was to confirm the diagnosis. However, he was not receiving adequate relief that he was feeling, and for the right shoulder, and the differential was a right rotator cuff tear, and indeed there was right supraspinatus tear with subdeltoid fluid. And here you have the supraspinatus tear and subdeltoid fluid. He also recently decided to get facet joint injections, facet joint blocks, nerve blocks, to help control his lower back pain. And here there's an X-ray showing that the nerve blocks are in position. And so if his small high-grade supraspinatus tear does not resolve in the next 3 to 6 months, he may be reevaluated as a possible surgical candidate. Thank you. I hope you enjoyed this.